It's 2026. We have artificial intelligence writing codes. We've got cars that drive themselves through rush hour traffic. We've got robots performing surgery with precision no human hand could literally match. Our hospitals look like something out of a science fiction documentary or something. We can see inside the human body without making a single incision. We've got sequenced your entire genome in a day. But if you're a woman with hip pain, your treatment protocol looks exactly like it did in the 1950s. Same diagnosis process, same tests, same limitations, same outcome. And here's what makes this really wild. It's not because of medicine. And here's what makes it really wild. It's not because medicine hasn't advanced. Everything else moved forward, just not the part that diagnosed your problem. That part kind of got frozen in time. Why? Money. Training systems that don't update. Let me take you back to the 1950s. Post-war America. The economy is booming. Medicine is advancing faster than ever. Penicillin is saving lives. The polio vaccine is in development. Surgery techniques are improving. And orthopedic, the specialist dealing with bones and joints, is becoming its own distinct field. Before this, general surgeons handled everything. Now, orthopedic is specialized. And they are figuring out how to diagnose and treat musculoskeletal problems systematically. Hip pain is common. Workers get injured, older people develop arthritis, the list goes on. So they developed a diagnosis protocol, a step-by-step process every doctor can follow. It looks like this. Patient history, when did the pain start? What makes it worse? What activities are limited? The doctor writes this down. It takes detailed notes. And next step is physical examination. The doctor moves the hips through various positions. Internal rotation, external rotation, flexion, extensions, checking the pain, clicking limitations. And the next step would be imaging, x-raying the hip joint. In the 1950s, x-rays are relatively new technology in widespread use. They're revolutionary. The first time doctors can see inside the body without cutting you open. Fractures show up clearly, arthritis is visible, joint spacing narrowing is obvious now. So the next step would be the treatment decision. If the x-ray shows structural damage, treat the structural damage or the structural problem. If the x-ray shows nothing, tell the patient to rest and it should improve. This is the model. Simple, logical, evidence-based for its time. And it works for what they're seeing in the 1950s. Hip fractures from factory accidents. You can see the break on x-rays. You set it, immobilize it, and it heals. Arthritis in older workers, you can see the joint degeneration on x-rays. You know what you're dealing with. Combat injuries in returning veterans, clear trauma, visible damage. For these patients, this diagnosis model has maybe an 80% success rate. That's good. That's working. So they write it into a textbook. This becomes the standard approach. Medical schools teach it. Residency programs drill it. Hospitals implement it. And you got to remember, in the 1950s, who are the most of the hip pain patients? Men. Older men with arthritis, working aged men with injuries. Women do have hip pain, but in the 1950s, fewer women worked in industrial jobs. Fewer women are in the medical system for chronic pain conditions. And when there's a different diagnosis category: hysteria, nervousness, female troubles. It's not taken as seriously. But that's a whole other problem. The point is, the diagnosis model is optimized for 1950s male patients with 1950 type hip problems. So it's been 75 years. In that time, medicine has advanced incredibly. 1977, MRI was invented. Suddenly, we can see soft tissues, not just the bones. 1980s, arthroscopic surgery became possible. Minimal invasive, faster recovery. In the 1990s to the early 2000s, CT scans, the 3D imaging, computer assistant diagnosis. The 2010 to 2020, genetic testing, personalized medicine, target therapies. All these advances, all this technology, but when you go to the doctor with hip pain, what's the process? Step one would be you describe your pain, and then you get the physical exam, and then you get the imaging. If the imaging shows damage, we treat it. If not, send it to PT or prescribe prescription pain medication. The structure is identical. The only difference, the imaging is better quality now. You can get an MRI instead of an X-ray. 9 out of 10 times you're getting an X-ray first, and then they push for the MRI, or you can push for the MRI. But the diagnostic logic, the way doctors think about it in the diagnosis, hip pain is the same. So why didn't this update? I can give you 3 reasons. Medical education, insurance incentives, and institutional inertia. For medical education is how the medical textbook works. A committee of senior doctors and professionals write each edition. So these senior doctors learned medicine 30 or 40 years ago. Their foundation training is from the 1980s to the 1990s. And what was considered foundational knowledge in the 1980s, the textbooks from the 1960s and the 1970s, which were based on the 1950s models. So you get this change. The 1950s, that creates the model. The 1960s, 1970s, writes into textbooks. The 1980s and the 1990s trains doctors with those textbooks. The early 2000s, 2010, those doctors become professionals. 2020s, those professionals write the current textbook. And at each stage, the fundamental model stays the same. Sure, there's new research. It gets added. New treatment options get included. But the core diagnosis framework, the step-by-step how to diagnose the hip pain process, that doesn't change. Because changing it would require admitting the old framework was incomplete. And medical institutions are deeply conservative. They kind of have to be, because mistakes cost lives. First, do no harm means being very careful about changing what works. But what works is relative. Works for whom? Under what conditions? For a 1950 male factory worker with hip fracture, that model works phenomenal. For a 2026 woman, 2 years postpartum with pregnancy-induced biomechanical changes creating a hip pain through compensating patterns, that model was never designed for that. In the 1980s, Medicare and insurance companies developed the CPT code system. Every medical service gets a code. Every code gets a reimbursement amount. So what gets codes? You got your office visits, you got your MRIs, you got your x-rays, you got your CT scans, you got your standardized physical therapy, you got your surgery, you got your medicine management. Notice what these are. They are all elements of the existing 1950s model. So what doesn't have reimbursement codes? Comprehensive movement assessments, about like 90 minutes, give or take. Postpartum biomechanical evaluation, functional movement screenings, pregnancy-specific physical therapy protocols, extended pattern analysis, coordination training. These things either don't have codes at all, or they have codes that reimburse so little it's not economical viable to even offer them to us. So here's a doctor's economical reality. Let's say their rent for their office building is $8,000 a month. Their staff salary, $25,000 a month. Now this is all just me rough estimate. So, and then say the equipment is $30,000 a month, insurance is $5,000 a month, supplies are $2,000 a month. I mean, we're just throwing numbers out there. So the total monthly overhead would be roughly $43,000 a month. To cover that, they need to see enough patients to bill enough. So a 15-minute appointment is $80 each. That's roughly $320 an hour. 90-minute comprehensive assessments are still $80. That's $53 per hour. The math doesn't work. So the doctor has a choice. You see a patient quickly, you order imaging, you follow standard protocol, you stay in business. Spend extensive assessments, you go basically bankrupt. Math is math in here. A system financially forces option A, not because doctors don't care, because the reimbursement structure makes economically impossible. Insurance companies effectively dictate practice patterns through reimbursement. The 1950s diagnostic model, because that's what exists when they created the code. Another reason could be institution inertia. Medical institutes are massive. Medical schools, teaching hospitals, residency programs, specialty boards, professional organizations, all interconnected, all with established procedures. You will have to change the medical school curricula, residency training program, board certified exams, continuing education requirements, clinical practice guidelines, insurance reimbursement codes, electronic medical record templates, hospital quality metrics. Each one of these is controlled by different organizations with different priorities. Say you want to add postpartum biomechanics to an orthopedic residency training. You need to convince the curriculum committee, but the curriculum is already packed. Residents already work 80 hours a week. They're already overwhelmed. If you add something, what gets removed? Hip fracture management, hip replacement technique. Senior professors ask, why wasn't this important when I trained? Why is it suddenly essentially now? Then you need the board exam to test it. Otherwise, residents won't prioritize learning. But the board exam committee consists of people who didn't learn this in their training. Is there enough evidence this is essential knowledge? This is research, but research takes years to become established evidence. Then you need clinical practice guidelines to change. These are written by professional organizations, a committee of experts convening every 5 to 10 years, reviewing all the evidence. They're conservative by design. They don't want to recommend changes until they're overwhelming evidence. From first research to change guidelines, typically 10 to 20 years. Meanwhile, insurances won't reimburse for anything that's not in the guidelines. So practices don't adopt it. Don't get me wrong, some practices do, but not all. So no, medical schools don't prioritize teaching it. It takes that doctor to dig deeper into this ordeal. Because let's think, no reimbursement, practices don't offer it, no data on effectiveness in the real world practices, guidelines don't recommend it, medical schools don't teach it, doctors don't know how to do it, no reimbursement. The system is stuck. And the 1950s model is deeply embedded in every part of this system. So what does this mean for you? Let's walk through what actually happens when a woman has hip pain today in the year 2026. You're 6 weeks postpartum. Your hip has been hurting for a few months. At first you think it will get better. You're tired. You're adjusting to being a mom. Your body hurts sometimes. But 3 months later, it's worse. It hurts when you pick up your baby. It hurts when you walk. When you wake up, it just hurts all the time. So you make an appointment with your primary doctor. First available appointment, 2 weeks out. You get 15 minutes in that doctor's office. You describe the pain, where it is, when it hurts, what you can't do anymore. The doctor types notes into the computer. They're actually required to maintain eye contact, but they're also required to document everything. So there's a lot of typing. They do a quick exam, move your hip through a few positions. Then they say probably just a muscle strain. Try ibuprofen. Rest when you can. Come back if it doesn't improve. 6 weeks later, not improved. Back to the doctor. Different doctor this time. Your regular one isn't available. Or so say they are available, but it's months out again. They review the previous notes, do another quick exam. Let's get an x-ray. Make sure there's nothing structural. Right? X-ray appointment. Hopefully it would be the same day, but sometimes it's a week out. You go, you get the x-ray. Takes 15 minutes. Technician says your results will go to your doctor. You wait. Say 3 days, a week. You finally get a call. Your x-ray was normal. Continue with the ibuprofen. Consider physical therapy. Normal. But you're not imagining this pain. You request a physical therapy referral. Insurance requires prior authorization. It could take, say, another week or so, right? Physical therapy appointment, 2 weeks out. They are booked. First session, the therapist sees you for maybe 30 minutes. They're managing 3 other patients at the same time. They give you the standard hip strengthening protocol. Clamshells, bridges, hip flexor stretches, sideline leg lifts. Do these 3 times a day at home. Come back twice a week. Insurance approved 6 sessions. You do the exercises. Your hip gets slightly stronger, but the pain pattern doesn't change. Session 6, the therapist discharges you. You made good progress. Keep doing the exercises. You're still in pain. It's now been 3 weeks since your first doctor's appointment. 9 months total since the pain started. You go back to your doctor. Let's refer you to an orthopedic specialist. Referral gets processed. First available orthopedic appointment, probably at the very minimum 6 weeks out. Finally see your orthopedic doctor. Fill out extensive paperwork, medical history, current symptoms, previous treatment. The orthopedic reviews your chart, does a physical exam. Similar test to what you've had before. The x-ray shows no fracture, but let's do an MRI to rule out the soft tissue damage. MRI requires special authorization. Insurance initially denies it. Your x-ray was normal, they say. Doctor's office appeals it. 30 weeks of back and forth. Finally get that approval. You get your MRI appointment. Say another 2 weeks out. You get your MRI. You lie still for 45 minutes. Loud banging noises. Uncomfortable position. And you cannot move. Your follow-up appointment to review your results is, say, another 2 weeks away. We're now 6 months from the first doctor's appointment. A year since the pain started. The doctor pulls up the images on the computer. They explain it to you. This is your hip joint. This is the cartilage. This is the labrum. I don't see any tears. No significant arthritis. No fracture. Everything looks normal. You're confused. You're frustrated. The pain is real. It's affecting your life. everything looks normal. Sometimes the pain can persist even without structural damage. Let's try a different physical therapy approach. There's a practice that specializes in chronic pain. Chronic pain physical therapy, another referral, another authorization, another wait. Or maybe I'm going to refer you to a pain management. They might try injections or other treatment. Pain management often means long-term medication management. Maybe a cortisone shot injection. The injection helps for, if you're lucky, a few weeks. Then the pain comes back. More medication, stronger NSAIDs, maybe muscle relaxers. But NSAIDs long-term can cause stomach problems. Muscle relaxers can make you drowsy. You're managing, but your life is limited. You can't get down on the floor and play with your kids the way you really want to. Exercise is painful, so you stop exercising. You gain weight from inactivity. Next doctor visit, have you tried to losing weight? That might help your hip pain. But you can't exercise because your hip hurts. And your hip hurts worse when you carry extra weight. You've seen 4 different doctors, done 3 rounds of physical therapy, had x-rays, you have had MRIs, and everything is showing normal. You start doubting yourself. Maybe it's in your head. Maybe you're just weak. Maybe other moms deal with this and don't complain. You talk to other moms. Turns out, many of them have hip pain too. Oh yeah, that's just mom life. Body changes after kids. It's normalized, expected. Just part of being a mom, but it doesn't have to be. So let's go back to that, to what actually happens in your body. During pregnancy, your body went through massive changes. Relaxins loosen every ligament, your pelvic shifts, your center of gravity changed, your muscles learned new patterns, your core essentially stopped working the way it did before. It had to make room for a baby. Your pelvic floor stretched and weakened. It's holding organs now, plus recovering from your birth trauma, whether you had natural or a C-section. Recovery after birth, some things recover automatically. Relaxin levels drop, the pubic symphysis heals, your uterus contracts. But some things don't automatically correct. Your muscle activation patterns, the specific sequence and intensity with which your muscles turn on, those don't spontaneously return to pre-pregnancy function. Your core muscles may not engage properly anymore. They learn to work around the baby you just had in your belly for 9 months, and they haven't relearned normal function. Your pelvic floor coordination, when it contracts, how much in what sequence with other muscles, that's all disrupted. And when your core and pelvic floor aren't providing stability, what happens? Other muscles compensate. Your hip muscles start working overtime. They're trying to stabilize your pelvic because the core isn't doing it. They're trying to control rotation because your pelvic floor, well, that ain't doing it. They're trying to support your body's weight distribution because the normal patterns have been disrupted. And overworked muscles, they hurt. They develop trigger points. They stay tight and they become painful. On an MRI, these muscles look normal. There's no tear, no structural damage, just muscle. The problem isn't structural. It's functional. It's not about what the muscle looks like. It's about what the muscle is doing or not doing. It's a pattern dysfunction, a coordination problem, a sequency issue. In the 1950s, Diagnostic Model can't see this because it only looks at structural bones, cartilage, ligaments, tears, fractures. To see function, you need a different assessment. You need to watch the person move. Test what muscles are activating in what sequence. Test stability in different positions. Analyze compensation patterns. This takes time. 60 to 90 minutes of initial assessment. It requires specific training in movement analysis. It requires understanding postpartum biomechanics. In the 1950s model doesn't include any of this because in the 1950s, they didn't have the knowledge. They didn't have the assessment tools. They didn't have the research on motor control and movement patterns. We have that knowledge now, but it hasn't been integrated into the standard diagnostic model. So women with functional movement problems fall through the gap. So here's what makes this really frustrating. Other countries updated their models. In France, every woman gets 10 to 20 sessions of pelvic floor physical therapy after childbirth, fully recovered by national health insurance. It's standard care. The therapist does a comprehensive assessment of pelvic floor function, core coordination, movement patterns. They catch problems early before they turn into chronic pain. The Netherlands? New mothers get home visits from I can't even say the word, but it's a maternity care specialist. They check on physical recovery, including movement patterns and core functions. Early intervention if problems are developing. Germany, similar protocol, comprehensive postpartum care extending months beyond birth. You get 1 6-week postpartum checkup in the US. The OB checks, did your uterus contract? Is your incision or tear healing? Are you using birth control? What doesn't get checked is our pelvic floor function, core coordination, movement patterns, hip mechanics. At 6 weeks, you are cleared for normal activity. So what does that mean? Your acute injuries are healed enough that you're unlikely to cause further tissue damage. It doesn't mean your body is functioning normal. It doesn't mean your movement patterns are healthy. And when the pain starts 6 months later, when the compensation patterns have had to create problems, you're in the orthopedic system using the 1950s model's diagnosis. That was never designed to diagnose pregnancy-related functional movement dysfunction. This isn't one personal story. It's a pattern that repeats thousands of times. Same timeline, same diagnostic, dead ends, same years of pattern. The system fails at predictable points. Point number 1 would be inadequate postpartum care. Point 2, you get diagnostic models that can't see functional problems. Point number 3 is insurance won't pay for what would actually help. Point 4 is treatment addresses symptoms, not the actual cause, which results women living with chronic pain that could have been prevented this entire time. Not because the knowledge doesn't exist, not because solutions aren't available, but because the diagnostic model hasn't updated since the 1950s. Because insurance incentives reward the old model. Because the training systems are slow to change. And because changing a system is always harder than keeping it the same. Even when the system is failing millions of people, the diagnostic model hasn't caught up, but the patterns don't